Hello, my name is Brian Raux. I'm a medical science liaison at Biomerieux. In this chapter, we will be focusing on staffing shortages and how they've impacted the microbiology lab and how labs may employ a syndromic approach to do more with less. Something that affects every field these days, both inside and out of the hospital, is a workforce shortage. This was a known issue before the pandemic started. In 2020, the Bureau of Labor Statistics predicted a nationwide need for an 11% increase in medical technologists and technicians by the year 2030. This was higher than the overall need for other occupations across the US, which was about 8%. There was a survey conducted that found about 7.2% of these medical technologist and technician positions were vacant nationwide. There are a variety of factors that are leading to this workforce shortage. First, the growing age of the community of folks that work in these positions are quickly approaching retirement. There's an increase in demand in the number of laboratory services. I'm going to showcase an example of that in a second. As we move toward precision medicine, the change in the practice of the clinical laboratory also changes the needs of the workforce staff, both in their education and their ongoing competency training. When we get down to the brass tacks of it, though, vacancy rates just exceed the number of MLS and MLT graduates. As we move into the COVID-19 pandemic, I wanted to showcase one example of how pressured laboratories could have been. So I live in South Carolina, so I thought it would be good to give an example from here. If we look at the first 10 months of the pandemic, from February through December of 2020, I know that seems like a long time ago, but I picked those dates because this is before home tests were really available. So all of these data should really reflect laboratory testing data. These come from the South Carolina Department of Health. And what they have showcased is that there were over 3.7 million tests performed by labs for COVID-19 in those first 10 months. For context, there are about 5 million people that live in the state of South Carolina. Unfortunately, this high volume of tests actually reflected about 329,000 cases and 5,700 deaths. If we look more longitudinally across the pandemic, from March of 2020 through January of 2022, the American Clinical Laboratory Association member labs performed over 175 million SARS-CoV-2 PCR tests. That's just PCRs alone, doesn't reflect any of the other different types of assays that are available. We haven't even touched yet on COVID-19 worker outages. So this is when people themselves are sick with COVID-19 and are unable to come to work. During some of the peaks, several hospitals in New York reported over 50% of their staff being out with COVID. And then this is a quote from Dr. James Crawford. He's a pathologist who was quoted on the issue. And he said, "We don't even have to invoke the big quit to acknowledge the challenge we have in the laboratory industry." So again, this just highlights that this was really a problem before the pandemic started, and has absolutely been exacerbated. When there aren't people to do the tests, the results can't get out there to the hands of the clinicians, who are then going to interpret and make treatment decisions. So some possible solutions would be to look into syndromic testing. So this is rapid. It usually goes directly from the sample to a result. It has low hands-on time, and it has an integrated workflow. So this means that you don't necessarily need a microbiology specialist to be setting all of these tests up. They have a broad coverage and have really revolutionized the clinical microbiology laboratory. They can look for bacteria, viruses, parasites, and even antimicrobial resistance genes all in one panel. This allows for the diagnosis of organisms that may be otherwise difficult to recover, and you can pool and combine results from multiple tests and the resources you would need to do all of those tests into one. With the ease of this testing, though, there are some limitations. We need to remember that these tests might not be appropriate for every patient. Some patients with select indications are the ones we might want to consider rolling this test out in. The microbiology lab becomes the ultimate gatekeeper of whether or not that institution sees the population that is appropriate for that test. Which really comes down to putting again back diagnostic stewardship and antimicrobial stewardship together. So if we look up at this figure in the top right of the slide, we have the clinician in the center taking care of their patient up at the top. They present with some type of illness, and the clinician evaluates them and says, okay, is this test the right test for the right patient at the right time? If a rapid diagnostic test, a syndromic test is appropriate, it would be ordered, performed by the laboratory, and the results would be reported out. An antimicrobial stewardship program then helps to take those results, incorporate them into the right treatment plan for that right patient at the right time. It all bundles back up to the patient where hopefully we see recovery. I'd like to now move into an overall conclusion and start with that stewardship starts with diagnostics. The benefits of an antimicrobial stewardship program are well established, and this ranges from small critical access hospitals all the way up to our largest academic medical centers. The COVID-19 pandemic opened many gaps for stewardship programs. Several of these chapters have covered 3 different ones, from increased antimicrobial use to increased antimicrobial resistance, and lastly, staffing shortages. But different programs may have seen these a little bit differently, and there certainly were others. We have to also remember that while this is a pandemic we're in the midst of, it's not the last one that we're going to deal with. So we need to take our lessons learned and figure out how to apply those in the future. Diagnostics may serve as the bridge to many of these issues. Effective antimicrobial stewardship programs will rise out of this with stronger diagnostic stewardship practices and hopefully find new ways to utilize what we already know as well as what we will learn to optimize patient care. Thank you so much, everyone, for listening. I hope that you're able to take all the information we went through in these 3 chapters and use them in your practice.